My name is Dr. Wendy Wright. I am an adult and family nurse practitioner. I have been a nurse practitioner now for 31 years. I practice in primary care, where I come to you from New Hampshire. So Charlene talked about how cold it is in Buffalo. It's mighty cold in New Hampshire as well. We have already received our first snowstorm. So it's coming, right, Charlene? It's coming. So I own a family practice. I have 11 nurse practitioners that work for me. We have 6,500 primary care patients. And I started the clinic by mortgaging my home 16 years ago with 7 patients. And so here I am today. I also own a medical education company where we give about 200 lectures a year to NPs, MDs, pharmacists, nurses, etc. So I'm going to get you started. You heard Charlene. I'm going to ask you questions as we go through, or stop and pause and say, do you have any questions for me? But oftentimes I'll answer questions as we go through, knowing what people often ask me. So I'll just take a break in a little bit if that's okay. And we're just going to roll today. We'll go through this first lecture and then we'll take a little break. We'll move into the next one so we can get you out at a reasonable time. So let's start with new drug update 2023. What's hot and what's not. My contact information is located here for you, as are my disclosures. And the purpose of this is so that you can evaluate me and any work that I do for any sense of commercial bias. Couple of things about this lecture. I am not here to promote any of these drugs. I am here to tell you that they exist. You will hear me mention generic names. I will mention brand once. I do that because when a new drug comes out, I don't know about you, but I don't know what that new drug is by its generic name. Once I've used it, then I will know that. So I will mention branded once, and then I will refer to it thereafter as a generic name. So here's what we're going to do. We're going to start out with comprehensive prescribing information on probably 8 or so new meds that have been released within the last year to 18 months. We will talk about how to prescribe them, drug-to-drug interactions. We will talk about warnings, and I will also talk about their cost, and I will also talk about, are they any better than any of the drugs we already have on the market? Then what I will do is we have part 2 tomorrow. I will give you quick updates, box warnings, and give you some idea of what's coming out and what we expect to see. The references for each of my programs are either on the slide or they are at the end of the lecture. So if you want to go back and look at any of the references that I've given to you, they are in your handouts. By the way, Charlene and her team have made my handouts available. Every slide you are about to see is in those handouts. So you should have copies of all of these if you need them. So let's start out by talking about this past year of 2022. I'm going to start with 2022. I have been teaching new drug update to a variety of different providers for the past 25 years. And every January, I create this new lecture of new drugs that came out the year before. For the first time ever in my career in 2023, so January of this year, when I did a look back on the previous year and all the new drugs, there were only 2 drugs that the FDA approved that had any hope of making their way to primary care. And that was a first. Usually there's 8 or 10 new meds that we see come out into specialty, but certainly primary care. And in fact, normally the FDA approves about 52 to 54 drugs a year. In 2022, they approved 37 medications, and only 2 were primary care based. The rest of them were rare and orphan diseases, things that you and I will probably never see or have a chance to prescribe. Lots of biologics, lots of oncology drugs, but very few primary care based drugs. But then the gates opened, and in the first 4 or 5 months of 2023, the FDA approved 14 new or novel medications, most of which are making their way into primary care. So over the next 2 days, when I do this lecture, you're going to hear me talk about most of these new medications. So let's start out with, and I break these lectures or these topics out into body systems or disease states. So let's start in the world of women's health. And let's start with a drug called ibrexafungerp. Its brand name is Brexafemme. And this is a product that is coming onto the market. It is an antifungal that is approved for postmenarchal females, as well as women with vaginal or vulvovaginal candidiasis. So when it first came onto the market, its only indication was the acute treatment of vaginal candidiasis. It has since gone on to get an indication for the prevention of recurrent infections. And the indication is that it will be taken once a month for up to 6 months to prevent recurrent candida. One of the places that I am seeing this being used as I travel around the country is in women who are on SGLT2Is that are offloading glucose into their urine and getting these recurrent candida type of infections. Because that class of drug has such compelling indications, you all know what I'm talking about: canagliflozin, empagliflozin, dapagliflozin. Not only are we using those to treat glucose and diabetes, we're also using those because they have cardiovascular indications to reduce heart failure, hospitalizations, and death, to reduce cardiac events and end-stage kidney disease as well. So when we are adding these to people with or without diabetes, we really want them to be able to stay on them. So one of the places, even though it's not indicated specifically for this indication, that I'm seeing physicians and nurse practitioners and pharmacists recommending this medicine is for people who are getting those recurrent candida type infections as a result of peeing out about 70 grams of glucose a day into the urine. So it works a little bit differently than a lot of the agents we have available. It inhibits glucan synthase, which is an enzyme that's essential for fungal cell wall development. So by blocking that enzyme, you can't develop or replicate the fungus, and therefore we're going to eliminate it from occurring. Now, it has in vitro activity against multiple strains of Candida, including the azole-resistant strains. I don't know what you're all seeing, but what I'm seeing in my clinic are women who call me up and say, I have used every over-the-counter product. I have used fluconazole multiple times, and I cannot get rid of these yeast infections. And the reason is because Candida, like bacteria out there, has developed resistant strains as well. So this is probably where most of us will pigeonhole this medicine, because when I show you the cost of the medicine, this is not going to be something that your average person is going to buy for a simple rank and file kind of yeast infection. So it's dosed, it's 150 milligram tablets. It's dosed 2 pills twice a day, and it's taken for 1 day only. So it's a 600 milligram dosage. They're going to take it 1 day, and the package insert says dose with or without food. My recommendation to you, I've seen that when people take it with food, there's less GI side effects. Its biggest side effect is GI related. And so I encourage patients to take it with food. I find that they tolerate it better. Now, what about the recurrent indication? 300 twice a day for the same day, once a month. So on December 1, on January 1, you're going to take 2 pills twice a day, and you're going to take it 1 day only of the month for up to 6 months. But for me, this next slide is where the rubber meets the road. So many of us call in medications like fluconazole for a patient who calls up and says, you know what, I've got this yeast infection. I'm not getting better with clotrimazole, turconazole. Can you call me in diflucan, for instance? This is a medicine I do not recommend you call in women of childbearing age. The package insert says you want to verify pregnancy or no pregnancy before this medication is used. So it's one thing if she's 60 years old and in menopause, it's another if she's 35 and capable of pregnancy. The reason for this warning in the labeling is when it was given to pregnant rabbits during periods of organogenesis, and while the dose was 5 times that of a human dose, those rabbits were born with missing forelimbs, missing pinna of the ear, and that is not going to be something you're going to want to test out in a human. In fact, the recommendation is verify no pregnancy and advise that woman not to attempt conception for at least 4 days after the last dose is taken. So for me, this is a really big, important point, at least in my clinic. We have about 2,500 adolescents and young women in our clinic. And so this is not going to be a product I'm going to give her without seeing her, verifying pregnancy, and ensuring that she's on some form of a reliable contraception. So to define efficacy, the clinical trial was double-blinded, placebo-controlled as required by the FDA. And they looked at what they called a complete clinical response. What is that? That symptoms were eradicated and culture was negative for Candida. So the study involved 18 to 78-year-olds. There is no dosing adjustment in people over the age of 65. And it is a CYP3A4 substrate. We're going to talk about this multiple times over the course of the next 3 mornings, because 60% of prescription drugs on the US market are 3A4 substrates. That means when you prescribe a strong inhibitor or a strong inducer, you're going to alter the efficacy in some capacity of those substrates. This drug is no exception. So if you have to prescribe a drug, so let's say they're taking ibrexafungerp and you need to prescribe or recommend a strong 3A4 inhibitor. There are 6 of them that come to mind when I think of strong 3A4 inhibitors. I think of ritonavir and nalfinavir. I think of Clarithro and erythro. Most of us aren't using many of those. And I think of itraconazole and ketoconazole. Of all of those, the one that's most widely prescribed out of that whole list these days is ritonavir. I haven't written ritonavir in decades until COVID. Are any of you writing the drug called Paxlovid? Paxlovid contains ritonavir-boosted nirmatrelvir, right? Ritonavir has 650 drug interactions. And so this is an example of that. So if they're using this med and you have to prescribe a strong 3A4 inhibitor, you want to dose reduce because they're not going to clear this drug as efficiently and levels are going to rise. So it's 150 2 times a day rather than 300 twice a day. And moderate inducers or strong inducers, hypericum, St. John's wort, rifampin, carbamazepine, those drugs have not been studied. They probably wouldn't harm someone, but they're going to clear ibrexafungerp probably more readily. It just won't work as well. So those are your interactions. When we look at that, some warnings, the good news is there's no evidence of QT prolongation. So much of what we are seeing now is the stacking of all of these drugs that have QT effects. And that's what gets people into trouble, is multiple drugs where there's QT prolongation. I have defended now over 100 malpractice cases involving nurses, nurse practitioners, etc. And what I've seen is that QT prolongation has become a topic in malpractice cases because of all of the drugs now that carry this warning. The good news is we're not seeing that with this drug, so folks do not have to be concerned about it, but it is because a lot of antifungals actually carry some QT effects. So what about efficacy? Remember that the FDA defined those metrics as complete clinical response, symptoms resolved, and culture negative. The efficacy was between 50 and 63%. Compared to placebo, which is between 28 and 44%. Both of those, I've given you the p-value, were statistically significant. Now, what about adverse events? GI side effects and bankruptcy. Those are the only 2, just kidding. Those are the only, what we saw here, diarrhea and nausea, but look at the GoodRx pricing for this. If you walked into a pharmacy and wanted to pay cash for this, it would be $494. Now, obviously, no one's going to spend that money. Any new drug, if you go out onto their website, brandnameofthedrug.com, you can find copay cards. A lot of these manufacturers will offer the $0 to $25. Why? Because they want to get people trying out these meds. They buy down the cost of the drug to get people on them. With that said, no one on federal plans are allowed to use those. Our Medicare, our Medicaid, and our TRICARE patients are not able to use any buy down programs. It is perceived as an incentive to use higher, more expensive medications. Now, there was just a release that came out in October this year that there was a manufacturing issue with ibrexafungerp, in that there was contamination that occurred during the manufacturing process on the supply chain line or on the manufacturing line. What that meant was they recalled many of these products that were out on people's shelves. And as a result, there is a supply issue. There is limited availability of this product in certain areas around the country. Just be aware that that has gone on. What questions can I answer for you or comments about ibrexafungerp? We have such a wealth of knowledge in this room. So if there's something you want to make a point about, please do, because I'd love to hear it. Yes, sir. That's a great question. I think it's the US. The question is, let me repeat that so everyone can hear. Where was this manufacturing occurring? I think it's the US, but if you at break, I will give that to you. And if I can't give it to you today, I'll give it to you tomorrow. Let me just make a note, but I'm pretty positive when I spoke with someone that it was US based. Any other questions for me or comments? How you doing? Doing okay? Let's get going with neurology. So I'm going to give you a little bit of the backstory. I think it'll explain as I go through this next section why I'm giving you this backstory. I'm going to start out with what many people have labeled one of the most controversial FDA approvals in the history of the FDA. And it's a drug called aducanumab, known as brand name Aduhelm. Have any of you seen this product, read about this product? So it was fast-tracked by the FDA. Fast-tracking means FDA looks at some of the data, says this has the potential to be very important out in the marketplace. The studies are not complete, but we see enough information at this point that we're willing to let it go to market. But manufacturer, you have to continue to study this drug. And if at any point we see that the drug is not efficacious or that the adverse events exceed the benefit, we're going to pull it off. And once you've done the studies, if we see that there's really benefit, we'll give you full FDA approval. It's very similar, everyone, to what they did with COVID and the vaccines and the antiviral treatments, where they said, we're going to give you an EUA, emergency use authorization. So they fast-tracked this drug. And that's important for you to know, because when we get to what's going on with CMS, it'll explain to you why there isn't coverage for this medicine. So it is the first in a class of drugs known as amyloid beta-directed antibodies. So you can see that the drug ends in MAB. What does that mean? It means it's expensive. That's what it means. So anytime you see a drug that ends in MAB, just know you're going to pay through the nose for the medicine, okay? It is a monoclonal antibody. And the thought is by a person, it's an IV infusion. By infusing this into the patient, what we're going to do is we're going to prevent the production of beta amyloid plaques. And by preventing the production, we're also going to prevent the laying down of those amyloid plaques in the brain. So who is it indicated for? Are patients with mild dementia related to Alzheimer's. It is an IV infusion. It starts with 1 milligram per kilo over the course of an hour, and it is infused every month. So 21 days or more. Most of the folks that are doing this are doing it once a month. Now, you can see that the maximum dose is 10 milligrams, and 10 milligrams is the dose we want to get people to. It is the most efficacious dose, but what is going to determine whether we can get people there or not is going to be what are called ARIA, A-R-I-A. That stands for amyloid-related imaging abnormalities. And there are two of them that I want you to focus on. One is called ARIA-E, that stands for edema. The other is called ARIA-H, and that stands for hemosiderin. And you're not going to get hemosiderin in your brain unless you've had microscopic bleeds. So these ARIA, amyloid-related imaging abnormalities, are really what the FDA is concerned about, and what we now know is a side effect of these antibody type of, or monoclonal antibodies. So in order to get this drug, they need to have an MRI within a year before starting the med. So there's this whole protocol. Their next MRI is after the 6th dose. Why? Because after the 6th dose is when they're going to go up to that 10 milligrams per kilo, or the most effective dose, but also the dose associated with the most adverse events. Then they get their next one after the 12th infusion, which means they've received 6 doses of the 10 milligrams per kilo dose. And radiologists who read these MRIs have been trained in what constitutes the need to discontinue, what constitutes the need to lower the dose, or what constitutes the ability to continue on this medicine. Theoretically, because these drugs are aimed at preventing one of the key drivers of dementia, Alzheimer's dementia, which are beta amyloid plaques, once people go on these drugs, they are theoretically going to stay on this class indefinitely. So I just snapped one image from one of the studies. There were 2 pivotal trials that were done to get this drug fast-tracked through the FDA. What I want to draw your attention to is that these are PET scans. These are MRI PET scans. And you can see that the top line on your screen are patients who got placebo. And what they're looking for is the accumulation or the amount of beta amyloid plaques seen on MRI PET scanning of the brain. And you can see that over 78 weeks of this trial, people who got placebo continued to have that the beta amyloid plaques accumulated slightly over that period in time. But take a look at that first dotted line that goes down. That's when they started on the meds, and you can see separation from placebo occurred within weeks of starting on the med. And if they continued on the 6 milligram per kilo dose, you can see that there is a checkered line that continues to trend down. But clearly that lower dotted line or checkered line is the 10 milligram per kilo dose. We see the best efficacy when people got to that higher dose. So that's all well and good, right? Because that's what we want. We want less beta amyloid plaque in the brain. But where the rubber meets the road, or what's really important to me, is what does this do clinically? How many of you remember over the course of your career the drug called niacin? Come on. Yes? Okay. How many of you remember putting people on high dose Niaspan? They used to say to me, I'm going to rip my clothes off. My skin is on fire. And I used to say, but it's going to raise your HDL. It's going to bring down your triglycerides. And then what did we find? 3 pivotal trials said it's useless. While it raised HDL and brought down triglycerides, it had no cardiovascular outcomes. That's why the American Heart has taken niacin out of the guidelines on treating lipid disorders, because while laboratory parameters improved, clinical outcomes did not. So then the question becomes, what does this do to patients' functionality? And they looked at a number of functional scales, including the Mini-Mental Status, the ADAS-Cog14, a number of different functional scales. And this is study 1, by the way. And you can see that every single one of those had a statistically significant p-value. Well, that's what we want. That was great. The problem was study 2 didn't have the same findings. In fact, many of them were not statistically significant. So people were like, wow, why did the FDA fast track this when one study showed efficacy and the other one didn't? Well, because the FDA said you need to continue on trials so we can understand this further. So I mentioned the adverse events, amyloid-related imaging abnormalities. Those abnormalities occurred in 41% of patients who were treated with the 10 milligram per kilo dose compared to placebo. Folks, I will tell you, it's one thing when you poop and have diarrhea in a clinical trial. It's another when you've got edema in your brain, right? On your brain, right? Or you've had microscopic hemorrhages. Now, many of these adverse events were mild and self-resolving, but this is obviously very, very concerning. So how common was the edema? 35% versus 3% on placebo. Hemosiderin deposition, 19 versus 7. Little bit of diarrhea, little bit of confusion. But here are the adverse events, and I've given you placebo as a comparator. So when this drug first came out, I feel like it's Johnson & Johnson maybe, or Biogen who made this drug. I don't even know who makes half of these drugs, but they launched it at $56,000 a year. And the thought is that once you're on this, this is what you're going to be on until this disease or something else takes you, right? Well, no one wrote the script. And the reason they didn't write the script was because people were concerned about the adverse events, and because CMS said single-handedly, this drug, if given to everyone in America who meets the criteria for it, single-handedly at $56,000 a year, it will single-handedly bankrupt the CMS system. Well, they said, we believe, this was a statement from CMS, we believe that this class of drug has the potential to provide benefit to our CMS covered patients. But until we have further data, the only way we're going to cover this drug is if people are in clinical trials. So I have 2 patients in their 50s with Alzheimer's dementia. I sent them to Dartmouth, which is my tertiary center in New Hampshire. And the P&T committee and the neurology group looked at the side effects, the benefits, and they said, we have decided that we are not going to introduce this drug into our community, and we are not going to administer it. So my patients are in their 50s, and I couldn't wait for this class to come out because they really are progressing fairly quickly. As you know, the younger they are with dementia, the quicker they progress. And I wanted this as an option. And Dartmouth and Boston said no go. So CMS said, we're not going to cover it unless they're in clinical trials. Then the manufacturer dropped the cost by 50%. So today it's around $28,000 a year. And the only way CMS will cover it is if patients are in clinical trials. So then what happened was April of 2023, CMS revised their statement. They then came out to say, we will now cover this class of drug if the drug is fully FDA approved. Whatever indication the FDA gives them, we will cover them as long as it's fully FDA approved and not fast-tracked. The first fully FDA approved was the second to market, and it's called lecanemab. It's sold as brand name Leqembi. Now, because this was second to market, but is now fully FDA approved, CMS is now providing coverage for this medication. So if you have patients who need this, this is the one that they're probably going to get unless they're in clinical trials because it is covered. Now, here's what I tell my patients. Covered is different than paid for. When patients say to me, is this lab going to be covered? Well, it'll be covered, but it's probably going to go to your deductible, right? That's different than paid for. So I never get in conversations with patients any longer about what's covered, what's paid for. I say to them, I have no idea what your plan looks like. We had a patient threaten to sue our clinic because she was charged $250 by Quest for a vitamin D that she was told by the nurse practitioner would be covered. So you know what? You never know what people are going to do. So here's what I say. Check with your insurance. It will probably fall under your Medicare coverage, whatever that looks like. And usually it's 10%, right? They have to pay 10% of what they incur for costs. But they're going to need MRIs with this as well. So they'll be paying 10% of those MRIs as well. So this is the second. It's an amyloid beta directed antibody, and it is indicated for both MCI, mild cognitive impairment, as well as mild dementia, Alzheimer's dementia. And you know that that line is very, very fine. It's hard to differentiate MCI from mild dementia, and not everyone with MCI goes on to develop dementia. So herein lies the real hard issue with this medicine. But you can see that lecanemab had the same outcomes in terms of beta amyloid plaque reduction. And you can see placebo at the top, 78-week trial, and you can see those dotted lines as we head down in terms of beta amyloid accumulation. They also did functional studies, including, and I just grabbed one out of the package insert, the ADAS-Cog14. That's one of our functional tools that we use to assess and monitor people with dementia. And their baseline scores were around 24. They monitored them over 18 months, and the lower the score, the better their memory, their functional scores are. And you can see that people that got placebo had a worsening of their ADAS-Cog score, and it was highly statistically significant compared to drug. That's what we want to see. But what's different with this med is it's also an IV infusion, but now it's every 2 weeks. So think about the burden on caregivers who are going to have to take their loved ones in every 2 weeks indefinitely. And they need an MRI before, they need an MRI after the 5th, after the 7th, and after the 14th infusion of this medication as well. And I pulled the ARIA adverse events. You can see that ARIA-E and ARIA-H also showed up in the lecanemab trial. And what did the numbers look like? So this is just information from study 2. Study 1 findings were identical to this, but you can see that symptomatic ARIA came in at around 3%. 29 out of 898 patients were symptomatic with their ARIA abnormalities, and serious symptoms were 6 out of 898. About 79% of patients completely resolved their symptoms and during the observation period. But that means 21% continued to be affected by symptoms. So this is what you can expect. But what's really great about all of this is that because this class is now being so studied with multiple companies working on new products in this class, we now understand who is most likely to develop these ARIA abnormalities. And it's what we call the APOE4 allele homozygotes. So this is a blood test that we can now do on a newborn if we chose to. We can assess that patient via a blood test offered through LabCorp, Quest, Mayo, and we can look and see, is this patient an APOE4 allele carrier? It's a genetic marker for dementia. And if they are homozygotes, those individuals are much more likely to develop the ARIA complications when compared to heterozygotes or people who are not APOE4 carriers. So what's now happening is before patients are put on this class of medicine, we now have a blood test that is run on these patients. If they are non-carriers or they are heterozygotes, they're probably not at an increased risk for ARIA complications. But if they are homozygotes, those are the ones where we saw most of the complications. And so if patients are asking you about this blood test, this is one of them that's out there. The other one that's available through your major labs is a beta amyloid plaque test. You can actually draw a blood test on your patients to see if they have beta amyloid plaque in circulation. It's offered through the major labs. And I've had patients come in and say, I want that test done. I want to know if I've got amyloid plaque so I know whether to worry about it or not. What we don't know is if they've got those plaques, are they going to accumulate in the brain? We don't have a good clinical correlate yet. All we know is we've got a blood test to test for that. So if people come in and ask you, it is available. So because this is FDA approved, Medicare, CMS has now authorized coverage for MCI as well as mild dementia. I've had people ask me, can I start this in people with moderate or severe? The answer is at this point, no, because we don't have studies on efficacy. Stay tuned. I think there are numerous studies ongoing, but the key with this is catching these people as early as possible. What questions do you have for me on these two products? Yes, sir.
Get 10%, 20, 30.
Yes. So the question is, what percent of people show up being homozygote? A very small percentage. 2-3% is what I've seen in clinical, in some of the publications that are out there. So it's a very small percentage of the population. But the APOE4 allele is a precursor or a genetic marker of Alzheimer's, particularly early Alzheimer's. So what's happening is we've got this population who is concerned about their memory, has dementia. So we're going to see more APOE4 allele, but a small percentage is actually homozygote. Yes, sir.
CMS covered for all the testing, MRIs.
Yeah, so so my understanding is that they are covering the whole protocol, but it's going to go to that patient's co-insurance, which I think, can anyone educate me? I think it's about 10% in Medicare. I think they're responsible, depending upon their plan. I think they're responsible for about 10% of all the costs. And you figure MRIs are what? At minimum $3,000, probably. So that's $300 times 4 or 5 in the course of a year. This is not going to be an inexpensive protocol. Then the question becomes, do we have to do them in the future? Once they get through the initial uptick, there's no recommendation to routinely monitor, but people are going to do that. And anytime someone has a symptom, we're going to do an MRI for fear that they've developed one of these adverse events. And then my last comment is, you all know where Medicare goes, so too does everyone else, right? People tend to follow that lead. Let's turn to the world of migraine. And in the world of migraine, I remember learning 35 years ago when sumatriptan came on the market that there was a neuropeptide called CGRP that we believed was the key driver of migraine headache. Is there anyone in this room that has migraines? A few of you, okay? So if you don't have a migraine yet, give me a few more hours. But if I hooked you up to an IV today and I infuse CGRP into your vein, it will immediately trigger a migraine. The way it works is it causes vasodilatation, influx of all these key mediators or inflammatory mediators into the brain, and that is what is believed to be the key driver of migraine. So we've waited for this class of medication to come out for over 30 plus years. The problem was designing a drug that didn't have significant liver enzyme abnormalities, which some of the first players in the field did. So it was about 4 years ago now that you started seeing these MAB products hit the market. Galcanezumab, drugs like Ajovy, Aimovig, Emgality, to name a few. Those were your subcutaneous injected MABs that blocked the release of CGRP. For those of you who deal with migraine patients, those drugs for many people are game changers. They're game changers. I've had people who literally after the first month of an injection have cut their migraine days down by 50, 80, and some people even 100%. So those are your preventive drugs. Then out came those are large molecules. Then out came your small molecule CGRP antagonists, your drugs like ubrogepant and rimegepant, Ubrelvy and Nurtec. You're all familiar with those. Those were indicated to acutely treat migraine. And then what happened was rimegepant went on to get a prophylactic indication or prevention every other day. And now we've got a nasal spray that has hit the market, also a CGRP antagonist. So what this does is it blocks the CGRP receptor sites so that even if it is produced, it cannot bind, it cannot cause vasodilatation. But how this class is different from the triptans is triptans prevent vasodilatation by causing vasoconstriction. This does not. So we can use CGRP antagonists in patients with poorly controlled hypertension. We can use them in people with stable cardiovascular and cerebral vascular disease. That is very different than the triptans. So this is your nasal spray that has come available, Zavegepant. Zazpret is its brand name. I want to spend my next career working in marketing. I have no idea how they come up with these names, but in any case, it is indicated for adults with acute migraine, with or without aura. I have zero belief that this drug is going to do much in the US market. Americans hate two things. They hate nasal sprays and they hate rectal suppositories. So I don't think that this drug is really going to gain a lot of hold, except the one place I am using this medicine is in my patients with morning migraine. These are patients who tell you, I wake up and I am already into a full-blown migraine. Remember that during migraine, people often develop gastroparesis. And so that's often why they're so nauseated and why they vomit, is because they develop transient gastroparesis. So this nasal spray is able to bypass that first phase of absorption, basically in the gut. And so I like it because it works quickly for people who are already into that migraine. What do I anticipate? I anticipate you're going to see this nasal spray at some point in the near future become indicated for cluster, because cluster ramps up so fast. It goes from a 0 to a 10 within 15 minutes. You need something that works quickly. I suspect you'll see this moving forward because it does work quickly. As of now, adults only with migraine. None of the CGRP drugs are approved to be used in children. Adults only. So it's a 10 milligram spray. It is one and done. One spray into one nostril at the onset of a migraine, and they can only use one spray in a 24-hour period. So the FDA designates the endpoint for clinical trials. And the endpoint is pain freedom. That means zero pain at hour 2 and freedom from their most bothersome symptom, either nausea, vomiting, photo, or phonophobia. So they did 2 double-blinded placebo-controlled trials. There were secondary endpoints like pain relief. That means they went from a 3 to a 4 down to a 0 to 1. Also, other endpoints return to normal function. You can see here compared to placebo, I just gave you one study so you can see efficacy. Pain freedom at hour 2 was around 23%, placebo was 14%. And then freedom from their most bothersome symptom was almost 40%, placebo was 31%. Those numbers don't sound real exciting, but both of them were statistically significant over placebo. And then if you look at the tables, you'll see that over time, if you look at the package insert, there is improvement over the 6-hour span after this medicine is used. The biggest side effect is dysgeusia. Dysgeusia is that taste disturbance. If any of you have taken the drug called Paxlovid, people talk to patients, they'll tell you that taste disturbance is pretty significant. So is this one. It was seen in about 18%. Here's my recommendation to you as you talk with your patients about using this spray. Keep your nose over your toes. That's what I tell my patients. Nose over toes. Don't tip your head back. If you tip it back, it's running down the back of your throat and it tastes awful. Number 2, don't snuff it in. So keep your nose over your toes. And then the other thing I say to my patient is opposite hand sprays opposite nair. So if you're right-handed, spray the left nostril. The reason is if you spray same side, same nair, you spray it onto the septum and you'll see a little bit more epistaxis. And that's with any nasal spray, opposite hand, opposite nair, and you'll spray it up into the turbinates and you'll see less epistaxis. But you can see here that that taste disturbance was the worst. There are no significant drug-to-drug interactions and none that are really expected. I've given you some of the package insert information, except one medicine, and that is intranasal decongestants. Drugs like Afrin, neosynephrine, etc., should be separated apart by at least an hour. So if they need to use this medicine, they shouldn't use a decongestant for at least an hour after they spray this into their nose. You never want to give a CGRP to anyone who's pregnant or lactating. In fact, most experts who study CGRP drugs say they want them out of people's system at least 3 months before a woman conceives, because there is some impact of CGRP on uterine contraction and pregnancy, and we don't have safety studies. We also don't have safety studies in people with advanced liver or advanced kidney disease. It is $1,000 if they walk into your pharmacies and pay cash for it. And that's 6 sprays. So it comes in a device, 6 devices, and it'll be about $1,000. Obviously, again, people aren't going to spend that amount of money. Let me give you one additional GPANT or one additional CGRP drug, and then I will stop for a second and answer any questions that you have. And that is atogepant. Atogepant is indicated for adults with migraine for the prevention of both episodic, and now I want you to add to your handout, chronic daily migraine as well. So episodic is defined as less than 15 headache days in a month. Now they also are indicated for chronic daily, which means 15 or more migraine days in a month. So essentially, this drug can be used in anyone who has migraine, who is indicated for a preventive med to reduce the severity and frequency of their migraine. It is indicated, so it's available in 3 doses. Folks, for the people who have chronic daily headaches, 15 or more migraine days in a month, the dose that is recommended for most efficacy is 60 milligrams. So 60 milligrams, 30 and 60 are your most efficacious dose. The reason you see multiple doses available is atogepant is a CYP3A4 substrate as well. So there are drug-to-drug interactions. And what we have to do is dose reduce this medicine in the presence of some other medications. So you can see here that if you're going to prescribe a strong 3A4 inhibitor, Clarithrol, ritonavir, etc., 10 milligrams is the dose of atogepant you want them to be on. If they're on a strong or moderate inducer, hypericum, carbamazepine, rifampin, you want to push the dose to 30 to 60 milligrams because they're going to clear this medication. And this medication is not only cleared through the liver, it is also cleared through the kidney. You want to calculate out creatinine clearance. If it is below 30 mLs a minute, the 10 milligram dose is the maximum dose we want to use. So what about efficacy? 2 double-blinded placebo-controlled trial drugs. They were allowed to use all their abortive meds, except they couldn't use any other CGRP acute drug. So they couldn't use rimegepant, they couldn't use ubrogepant, but they could use all other acute medications. So I just grabbed one study for you. And what you can see here is the monthly migraine days are across the top. And this is pretty normal, by the way. Most people who enter clinical trials who have episodic migraine have on average 8 migraine days a month. You all know we're no longer talking about migraines in terms of how many migraines you have. We're now talking about them in terms of migraine days. Because you and I all have patients who have migraine who tell you, I have 1 a month, but it lasts 5 days. So that person would have 5 monthly migraine days. The American Academy of Neurology says people warrant preventive meds if they have 2 migraine days a month that produce severe disability. So 2 or more that produce severe disability, 3 or more that produce moderate to severe disability. So these people had on average 8. At 12 weeks, you can see that their monthly migraine days, placebos on the right, were reduced by 2.5, whereas the 60 milligram dose cut their monthly migraine days down by 50%. What you are going to hear in the world of neurology more and more about this drug is using this drug in combination with Onabot or Botox, because we believe that the Onabot, the Botox injections that people are getting for their chronic daily migraines, works differently than does atogepant. And when the two are combined for the toughest migraine patients, there appears to be an enhanced effect. So a lot of the discussion these days is that combination therapy in your patients who have that chronic daily migraine. So we don't use this in pregnancy, in lactation. It has not been studied in severe liver disease. It's actually fairly well tolerated. Nausea, constipation, so GI side effects. The one thing I do want you to know about is the literature. There are now reports that have been sent to the FDA that about 4% of people who take this medication are experiencing unexplained weight loss. Now, in America, that might be a good thing, right? But in our world, when we hear unexplained weight loss, to us, that's a bad thing. That's a malignancy that I haven't figured out yet, right? So I just want you to be aware, because people have lost 5-10% of their body weight after starting on this medicine, for a medicine we don't know why. Could it be the decreased appetite? We don't think so, because it didn't appear to be correlated in the trial. What's the mechanism? None of us know, but stay tuned and be aware that those reports are now out there. Again, it's about $1,000 a month for cash. What questions can I answer for you on these two medicines and migraines? Yes, ma'am.
What is the expiration for these? I find that my Emitrax injections expire really fast, and they're expired by the time I need them again.
Interesting. So these medicines, we have some samples of these in our closet, and their expiration date that I've seen is late 2024, 2025. And I'm going to tell you this because this is what I do, is even though many of the meds are expire, most of them are probably not expired. Most of us have expired meds that we use at home, wink, wink, that have been sitting in our closet for months beyond their expiration date. But I've seen that these have a pretty healthy expiration date. When you're desperate, and just because, remember, the FDA mandates an assigned expiration date depending upon how they're produced, et cetera. And we know that most of them don't go bad at that day. In fact, I mean, I say to some of my patients who have such social determinants of health that they can't afford food, let alone medicine, I say to them, if you're willing, I would take this medicine. It expired 30 days ago. I don't think it's expired. But if you're not willing, I mean, I know I shouldn't be doing that, but I do. Other questions? Yes, ma'am. Yes. So the question is, do I see them being used in an emergency room setting? My gut is probably not. And the reason is they're so darn expensive. In an ER, many of us, I use Ketorolac. So when people come in, I give them Ketorolac with some Zofran and a liter of fluid. And I can break a good significant amount of migraines, status migrainosus, by doing that. I think these are too costly. Now, can they be recommended? Maybe, yes. Most of the time, you have to have failed 2 other meds in order to get these meds approved through the insurers. And I see a lot of pharmacists nodding their heads. I have someone who works in my clinic 40 hours a week, and the only thing she does is work on prior auths with all of you. And I'll tell you, it is disgusting that I have to spend $75,000 a year to employ someone that all they do is work on trying to get a $10 drug approved, because every insurance company has gone to this. And it's not just drugs, it's every imaging as well. It's just sick, actually. And I understand that meds are expensive. It's just because they know people are going to give up and they're not going to fight for these folks. So, but as my staff says, please stop prescribing those weight loss medicines. That's because that's the other challenge, which we'll talk about in a second. Other questions for me? Is everyone doing okay? Feels like it's cooling down a little bit. I was about to take off my Spanx and get naked up here. Does everyone feel like it's cooling down a little? All right, that would be the most memorable conference you've ever attended in Kauai. All right, this 57-year-old body. All right, let's go to daridorexant, also known as QUVIVIQ. And some of you remember that about 10-ish years ago, a med came onto the market called suvorexant. You knew of that as Belsomra. It was the first in the orexin class to come to market. I was so excited when it came to market. I was less excited after I fought to get it approved, and it appeared not to do a dang thing. The problem is that the FDA approved it at a dose that was way too low. Most experts tell you it should have been approved at 20 milligrams, but because it was a new medicine coming to market, it was a 5 milligram approval. You titrated up, you went to 10, but 20 was probably the dose everyone needed to be on. Then out came the drug called lemborexant. You knew of that as Dayvigo. Didn't really gain much hold in the market, and this is the newest one to hit the market. When I was in graduate school, I didn't learn at all about orexin antagonists, and that's because I was in school in the 90s, early 90s, and it had yet to be discovered. Orexin is a neurotransmitter that is involved in our wakefulness. So by blocking orexin, you turn off the wakefulness center instead of turning on the sleep center like we do with the Z drugs, the zolpidems and the Zalopons. That's how I explain it to my patients. And I think it's important to explain that because if you're looking for propofol, is what I say to them. If you're looking for propofol, this is not propofol. It is not going to knock you out and put you into a coma. Now, I still have people ask me, do you think I could get propofol? My response was, it didn't work well for Michael Jackson. So the answer is probably not. This induces a gentle sleep. It turns off the wakefulness center. So if people have already tried Zaloplan and Zolpidem, they're going to say to you, this doesn't work. It actually does work, but it's just, they've got to give it time. None of the orexin antagonists should ever be used as needed. They don't work well as needed. And the longer they stay on this class, the more efficacious the medication becomes. So you will see the benefit continues to improve. And part of that may just be the fact that when they've got a drug that they know is going to put them to sleep, they're not so anxious getting into bed. You know, the average patient in this clinical trial that were given this drug had insomnia for 11 years. I want you to think about 3 times a week for at least 3 months of your year. You get into that bed and you do that for 11 years and you know you're not going to sleep. It's an awful, awful feeling. If any of you have ever had insomnia, I'm very thankful. I've had transient insomnia, but I love my sleep. It's actually one of my most favorite parts of the day. So if people can't sleep, it's horrible for them. So this is indicated for adults with insomnia who either have difficulty falling asleep or difficulty staying asleep. So it works across the entire sleep cycle, and none of the orexin antagonists are believed to alter sleep architecture. None of them are believed to alter sleep architecture. The FDA approved it as 2 different dosages, 25 and 50. Folks, my recommendation to you, the FDA said there's no starting dose. You may start at whatever dose you think is appropriate for your patient. My recommendation is start at the 50. Because the 50 is the most efficacious dose and the adverse events are pretty identical to that of the 25. And so you want people to sleep and you want it to work fairly quickly. The 50 is what is going to get you there. So what can you tell people? The average patient in the clinical trial took more than 60 minutes to fall asleep. This medicine is going to reduce that time by 30 minutes. So you want to tell them to put on their PJs, to take the medicine, and then get into bed. It also cut down, the average patient in the trial slept about 5 hours a night. We have some visitors in here. So the average patient in the clinical trial slept about 5 hours a night. It gave them an additional hour in the clinical trial. But this is the first medication on the US market to actually study daytime sleepiness as well. And patients who took the 50 milligrams had reduced daytime sleepiness. And people who took the 50 milligrams had less falls than people who took placebo. The thought is they're not waking up as much and they're not as sedated. So it has an 8-hour half-life designed to mimic a normal night's sleep. It began to separate from placebo at the 1 and 3 month mark, or it did separate from placebo. Those were the 2-month marks that were studied in the clinical trials and continued to improve for over a year. I want you to cross out this box on the right-hand side that says send prescriptions to VitaCare. They have discontinued their work with VitaCare, which is a specialty pharmacy in Boca Raton, Florida. This is now available through all of the commercial pharmacies as well. And in general, my experience with Daridorexant is they have to have failed 2 other agents to get this product available. There is, so the adverse events are, you can see here, 6 and 7% headache. That's 25 and 50 milligrams respectively, and then 5% for placebo. And this product is, I didn't give you the cost, this product is about $4 a pill, about $4 a pill. Questions for me on Daridorexant? Let's go to cardiology. Let's talk about this drug called inclisiran. And inclisiran is being sold as Leqvio. So it's coming onto the market to compete with what my patients call super statins. Those are drugs like evolocumab and alirocumab, Repatha and Praluent. So these are drugs that are given to people who are on maximally tolerated statins and are given to further lower LDL. How many of you remember the day we used to say everyone in America needs an LDL under 100, right? Then the high-risk people needed LDLs under 70. Then the American College of Cardiology came out and said, just put them on a moderate intensity, put them on a high intensity, and we're not worrying as much about the numbers, right? Well, now we're back to numbers again. The ADA says for your patients with diabetes, they need an LDL now under 70. And for your patients with diabetes and heart disease, they need LDLs now under 55. So these are going to be meds that are going to be added on to people who have familial hypercholesterolemia. I saw a patient in my clinic last week before I headed out on the road. Her LDL was 360. She said to me, I'm not going on any medicines. I said to her, you are a sitting duck for atherosclerotic cardiovascular disease, and you don't get to pick whether you have an MI and die in your sleep or whether you have a stroke and live in a long-term care facility. She said, I don't believe that this is affecting me. I said, then let's do a coronary artery calcium score and let's see what your blood vessels look like. What's a normal CAC? What do you want someone's CAC to be? 0. Hers was 1100. By the way, at 100, that's equivalent to a 10-year ASCVD risk of 75. I said, pick your battles. You need to go not only be on a high-intensity statin, you need to be on evolocumab or alirocumab, and you need a cardiologist ASAP. And so it's scary. It's scary. So familial hypercholesterolemia is what she has. Remember, you either eat your LDL or you make it. You eat 20% of your LDL. So at 350, she could diet until the cows come home. She will never normalize that LDL. Now, it's also for people as an add-on to a maximally tolerated statin who already have atherosclerotic disease. And it just got an indication for primary hyperlipidemia. I anticipate that this is going to be used in people who can't go on a statin. But I want you to hold a little bit on this medicine. And the reason is we don't have any cardiovascular outcome studies. We know it lowers LDL. We suspect we'll see benefit from it, but we just don't have those studies yet. And that's why I think we're not seeing as many people prescribe this, that and the cost of it, because we just don't have the outcome studies yet. So remember how the PCSK9s work, right? PCSK9, it's an enzyme in our body. What it does is it degrades the LDL receptors sitting on the surface of the liver, breaks them down, rendering them unavailable for LDL binding and LDL clearance. This drug is what's called a small interfering RNA particle. It's one step before the PCSK9. So they can't make the PCSK9 so that it can't then degrade the LDL receptors. So it's kind of one step before. So we're going to use one or the other, not both of these. We either use the PCSK9 inhibitors or we use the inclisiran product. So it's going to lower LDL. It's a subcutaneous injection. As of today, it's supposed to be given in our clinics. I anticipate that what's going to happen is over time, as we get this product more commonly used on the market, because it's subcutaneous, there will be an auto injector and people can just do this at home. It will be administered every 6 months in our clinic. So in the clinical trials, in patients with hyperlipidemia and atherosclerotic disease, I just grabbed one study. They were already on a maximally tolerated statin. It further lowered LDL by 51%. Pretty impressive. After already being on a statin that is capable, maximum tolerated, depending upon what they could tolerate, also lowers LDL 50% or so in the high intensity statins. It also lowered ApoB, that atherogenic lipoprotein, by 45%. So there were 1,800 patients in the clinical trials, and look at the number. 7% of them were 65 and older. So the good news is we have safety data in our older population, which is often going to be the population that is going to be on this medication. The biggest adverse event was injection site pain and swelling. There were a little bit of arthralgias, bronchitis, nothing probably related to the drug, but this is not a drug we would ever give to a pregnant woman. She needs cholesterol for gonadal development. And so we don't give any cholesterol lowering agent to a woman who could potentially become pregnant. It has not yet been approved in kids, but I do anticipate at some point, like everything else out there, I think atorvastatin is now approved down to 8 years of age for kids with lipid disorders. And I think Rasuva is approved, I think, down to 7 or 8 years of age as well. And so the cost of this injection is $3,250 a dose. The problem is I can't send this script to the pharmacist here in the room. I have to order it from a supply company who then bills me, and then I bill out. I give it to the patient, and then I bill out to the insurance. I don't know of a lot of family practices that are going to be willing to purchase a drug for $3,000 and pray that the insurance company decides they're going to pay us, right? So I anticipate that this is a drug that's probably going to be given in lipid clinics until which time as patients are able to self-administer at home. And then I anticipate that it may be able to be purchased through retail pharmacies as well. And one other cardiovascular drug before I take a break here. Oops, I keep hitting the back arrow. So we've covered the cost. Let me talk about a drug called finerenone. And finerenone is a drug that is now in the ADA guidelines. And it is a drug that's an MRA. So it's a mineralocorticoid receptor antagonist. It's coming onto the market to compete with spironolactone and eplerenone. What's different is both spironolactone and eplerenone are steroidal MRAs. Don't we use spironolactone in male to female transition? Patients who are transitioning male to female to block androgen. We also use it in patients with PCOS to block androgen and reduce hirsutism, et cetera, in women with PCOS. What's different is this is non-steroidal. So this will never be used in PCOS because it has no impact on estrogen, androgen, or any of the hormones. Its indication is type 2 diabetes and kidney disease to reduce end-stage kidney disease and dialysis, heart failure and death and hospitalization, cardiovascular events, and cerebral vascular events. That's a pretty darn broad indication, but it met its primary endpoints was to look and see if we add this drug on in people with diabetes who already have kidney disease, can we reduce their rates of MIs, strokes, heart failure, death, and end-stage kidney disease? And it met its endpoints. Here's what I see. Nephrologists are adding this on now to the SGLT2Is in patients with kidney disease and diabetes that are already on those but continue to have worsening GFR. The other place I'm seeing it used is in people who cannot tolerate an SGLT2I because of UTIs, pyelonephritis, and so they're being put on this medication. The dose we are going to use to start them is going to be dependent upon their GFR. Now, I've had nurse practitioners when I did this lecture say, why are we putting this on board in someone whose GFR is 60? Remember, there's actually 3 ways to define kidney disease. One is by GFR. 2 is by their UACR, their urine albumin creatinine ratio. For years in patients with diabetes, we did a microalbumin. Yes or no, you've got protein or you don't. Now we do a urine albumin creatinine ratio. And if that number is greater than 30, that patient has kidney disease, regardless of whether their GFR is normal or not. And then the other way is structurally. So if they've got an atrophic kidney, that is someone with kidney disease, or they've got polycystic kidney disease, they've got kidney disease. But in the world of diabetes, it's GFR and it's UACR that we are now watching and trying to mitigate risk by getting people on these meds to slow progression. What is going to determine how high we can push the dose is 4 weeks after we start this medicine, we bring them back and check potassium. You all know that the MRA drugs are known for hyperkalemia. If that potassium exceeds 5.5 or it exceeds 5.5, we need to stop this medicine because people with kidney disease are usually already on a RAS inhibitor, right? They're already on an ACE or an ARB, and they tend to, because of the kidney disease, retain potassium. So you have to watch potassium very, very closely. In the clinical trials, it was around 18% of patients developed hyperkalemia. So the efficacy met their primary endpoints, reducing all of those metrics that I spoke with you about. And you have to avoid strong 3A4 inhibitors with this drug. So let me give you an example. Let's say they're on finerenone and they get COVID and you prescribe ritonavir boosted nirmatrelvir. You are going to increase the area under the curve of finerenone by greater than 400%. That can cause hyperkalemia. It can cause adverse events. And so you want to be very careful. You also want to tell people on this drug to avoid grapefruit juice because it's a moderate inhibitor. So it's going to raise the levels of this drug as well. And it has not been studied in pregnancy or in lactation. Your biggest side effect is hyperkalemia at 18%. Questions for me on cardiovascular? We've got about 10 minutes left, so we're going to go to break somewhere around 9:30. We're going to do these rolling breaks, but we'll get you out in just a few more minutes. Any other questions for me before I wrap this up? Okay, let's talk about ritonavir boosted nirmatrelvir. I've mentioned it multiple times. This drug is now fully FDA approved. So instead of being under an EUA, it is an FDA approved drug. So I had a patient come in to me probably about 9 months ago, and she said to me, I am not going to take that medicine. I said, well, why? She said, it's not fully FDA approved. I said, neither are there 22 supplements that you've got listed on your list. None of those are FDA approved either. Well, they're different. How? How are they different? At least there were double-blinded placebo-controlled trials that were EUA authorized. Well, it's different. This is where sometimes a little knowledge gets people into a lot of trouble, right? So it is indicated for the treatment of COVID, mild to moderate COVID-19 in adults and children. So 12 and older, they must weigh a minimum of 88 pounds And I want you to cross out the term that is in your handout that says positive test. The CDC now has come out to say people no longer need a positive test for COVID to take any of the antiviral treatments that are now available. The reason for this is, have you ever seen people you know they have COVID? They can't smell, they can't taste, they're coughing up a storm. They've done 22 home COVID tests and none of them come up positive, but you know they've got COVID. Then the recommendation is to treat them if you're pretty convinced that that is what they have. It also is given to people at high risk for progression on to severe disease, including hospitalization and death. So when I have a 25-year-old with no health risks whatsoever, I am not prescribing this medicine. Our fear is that if it is overused, we are going to end up seeing resistance like we are seeing with other products. So it's really recommended for people who are at high risk. What is the number one risk for hospitalization and death from COVID? Age. And every decade you go up, your risk increases about 55%. Do you know people in long-term care facilities comprise 30% of all deaths in the first year from COVID, yet they represent 1% to 2% of the US population? Age is the risk factor. Now, certainly obesity and asthma and heart disease and diabetes and lung disease, those are all risk factors as well, but age is your strongest risk factor. So how does it work? The drug, so nirmatrelvir is a protease inhibitor that inhibits viral replication of SARS-CoV-2. So what did they do? They added ritonavir to this and used the interaction, the 3A4 inhibitor, to boost the efficacy of NIRM to prevent it from being broken down. So that's the role ritonavir plays, is it enhances the efficacy of nirmatrelvir by preventing it, by raising levels and preventing it from being broken down. So to get the first EUA, they did phase 2-3 double-blinded placebo-controlled trials. And what they looked at was COVID-related death and hospitalization at day 28. And what they found was people who got the drug, it was 8 versus placebo 66. And so this is what led to the EUA approval. They have since gone on to submit multiple other studies now to the FDA, which is what resulted in full FDA approval. Now, I want you to notice that it says, initiate as soon as possible after COVID-19 diagnosis. Annals of Internal Medicine this week published an article showing that if this drug is started within 2 days of the onset of symptoms, 20% of the people who were given the drug actually had viral rebound. Whereas if it was started after day 2 of symptoms, there was less viral rebound. So this is what the insert says, but I want you to be aware that there is some discussion now about should we be changing, maybe we started on day 3 or day 4 of symptoms and maybe started a little bit later. Stay tuned, we don't know. This is a moving target, but I think it's really, really fascinating. So it comes available in a packet, right? It's 2 of the nirmatrelvirs and 1 of the ritonavirs. They take it twice a day. They take it for 5 days. There's also renal dosing. So I have a lot of nurse practitioners who have said to me, I work in urgent care. I don't have labs available. Then you know what? Then prescribe the renal dose if you're at all concerned that they might have kidney disease. But here's what I do, because I have a lot of patients who come into our clinic for an urgent visit. I'll say, do you have any labs in your phone? They all have portals. They all have a lot of their labs on their phone, and they can pull them up. I'll ask them to pull them up. And if I'm not sure, I'll order up a CMP so I can get their creatinine and their GFR. And then I will wait until the next day to prescribe it. 1 day is not going to make a difference. But if you give them too high of a dose and they've got kidney disease, they're going to have increased adverse events and side effects. It is not approved for anyone with a GFR under 30. By the way, the only COVID drug you can give to people with a GFR under 30 is the drug called remdesivir. Remdesivir just got an FDA approval to be used in patients on dialysis. So for those high-risk patients. Now, look at the drug-to-drug interactions, 650 of them. And the FDA has received multiple reports of adverse events because of people prescribing meds and having an interaction. What are the two most common interactions being reported to the FDA? Statins and calcium channel blockers. I tell people when I'm doing this lecture, there's a great app called the Liverpool Drug Interaction Checker. Download it. It's free. Epocrates has a good one as well, but Liverpool was really enhanced to pick up the interactions with this medicine. So I think there are some really good drug interaction checkers. The biggest side effect of this drug is dysgeusia. And that's a taste disturbance. And I've had people say, I tried lemonade, I tried iced tea, nothing works. But I had an NP tell me the best thing. She said, Wendy, the best thing you can teach your patients is when that awful side effect, that awful taste leaves their mouth, they're due for their next dose of the medicine. Because she said within about 10 or 11 hours, the adverse side effect or the taste disturbance goes away. That's a reminder you're due for your next dose. All right, so let's talk about molnupiravir. The NIH came out and said, in order of what medicines people should take, ritonavir boosted nirmatrelvir is preferred as first line. And by the way, I didn't tell you, now that the COVID emergency has been removed or declared over, we now have to pay for this medicine. It's no longer available free of charge from the government. And it's $1,000 for Paxlovid for 5 days. Pfizer's getting a lot of heat about that. It's about $1,000. Molnupiravir is last on the list from the NIH as the drug that should only be used when nothing else is able to be used. So ritonavir boosted NERM is number 1, remdesivir is number 2, outpatient, and number 3 is this drug. Did any of you read the article that came out that said the concern with this medicine is that it may be actually contributing to the subvariants of COVID? Because the way that it works is it embeds an error in the genome, the sequencing, and it leads to errors in viral replication. This is a medicine only approved for adults, again, at moderate risk, and they do not need a positive test as well. So they looked at the efficacy in what's called the Move Out trial, and they looked at something very similar to Paxlovid. And you can see they looked at hospitalization and death through day 29. You can see that it was higher in the placebo arm compared to the molnupiravir, but not as robust as what was seen in the previous drug. It also comes available as a pack, and it should be started as soon as possible, ideally within 5 days. There is no dosing adjustment for people 65 and older, but this is the most important takeaway. Women should not take this med if they are capable of pregnancy. This drug, when it was given to rats during a period of organogenesis, those rats had severe teratogenic effects. It was 8 times the human dose. Here's the recommendation. Women should have a pregnancy test prior to using it if there's any chance they're could be pregnant. And men are now advised to wear condoms for 3 months after they take the last dose of this medicine if they are having intercourse with a woman of childbearing age or capable of pregnancy. And it's well tolerated. It also hasn't been studied in people with GFRs below 30. And why is it third on the list? And this is my last slide. I'm happy to take any questions at this point. Why is it last on the list? It's probably the least efficacious. And this was a panoramic randomized controlled trial that was done. They took 26,000 patients who had already been vaccinated against COVID. And when they got COVID, they either got placebo or molnupiravir. And you can see that it did not reduce hospitalizations or deaths, but it did improve recovery time. There was less primary care services, and there was a reduced viral load. So I'm not sure how much longer this will be around. It is still under EUA authorization. It is not FDA approved. So I'm going to stop here. What questions yes, ma'am.